From Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about living with osteoporosis and treatments for it. Our guest today is Dr. Angela Boldo, an endocrinologist here at Sarasota Memorial. Dr. Boldo, thank you so much for being with us.
Thank you for having me.
Let's start with the basics. What is osteoporosis?
So osteoporosis is the decreased strength of the bone. It usually happens with age. Women have it more than men because they lose estrogen production with menopause. So all women will start losing some bone strength, it increases bone reabsorption after menopause. So depending on the genetics and how strong your bones were when you're young, you get at least osteopenia, and about a third of the women will get osteoporosis in their lifetime. Men don't have menopause, right? So they have testosterone production at decreased levels, but some testosterone for the rest of their life. So they don't get osteoporosis as frequently as women, but they have it as well. Unfortunately, because men don't get screening for osteoporosis, a lot of times they find out only after they have a fracture. So that's the biggest problem with osteoporosis. You don't feel it until you break. So that's why for women, that's more prevalent. We have screening for osteoporosis, usually starting around 5 to 10 years after their menopause.
So you mentioned a lot there. Specifically, are there any symptoms which sometimes people might be on the lookout for before they have a fracture or a break?
Really no symptoms.
Wow. Okay. Yeah. And you also mentioned osteopenia. What's the difference between osteopenia and osteoporosis?
So you achieve what we call peak bone mass when you're young, around age 20 and 30. That's how the strongest your bones will be. And then when you start losing bone density, you get first to osteopenia, where there's no big increase in fracture risk. It's more like a warning. Your bone density is going down. Your bones are not as strong anymore. And in osteoporosis, it's a definition based on numbers on the bone density. So when you get to osteoporosis, your fracture risk is high enough that it warrants treatment. In osteopenia, some people do have increased risk of fracture, then it's related to age. So even in osteopenia, sometimes we recommend treatment in women or men that are above age 70, 75. If they have osteopenia that's almost osteoporosis, they're already at increased risk as well. So not always we recommend treatment at osteopenia. It's more age related, and if they had previous fractures. So if you have osteopenia, but you had a fracture that tells us your bone strength is not good, a fracture that shouldn't have happened, then we call that patient, we do call that osteoporosis even if the numbers are in osteopenia. So a lot of people get confused saying, oh, my numbers are not in osteoporosis, but if your numbers are in osteopenia, but you had an osteoporotic fracture, we still treat because it's an increased risk for another fracture. So fractures that we consider osteoporosis fractures that shouldn't have happened if your bones were strong, is hip fracture, like big bones that shouldn't break with a standard fall, with a fall from standing height. So a hip fracture, a femur fracture, big bones, spine compression fractures on the vertebra of your spine. Those are strong bones and they shouldn't break if you just fall from standing height. So if you have a fracture like that, we call that a fragility or an osteoporotic fracture. And those are the fractures we're trying to prevent when we talk about treatment. Those are the fractures we're trying to prevent because they can really impact your life, cause chronic pain and overall decrease the activities and exercises you can do.
How many people are actually impacted by osteoporosis, whether knowingly or unknowingly?
So the older you get, the higher the risk. So when you get to your 80s, about 80-90% of women will have at least osteopenia. about 30-40% will have osteoporosis in their 80s. So it gradually goes up from menopause, where the majority will have normal bone density, to like almost everyone will have at least osteopenia in their 80s. Men is about half that. So that's why when we talk osteoporosis, we think women, but men can also be affected, but just less frequently.
So you mentioned gender, you mentioned age as big risk factors.
Yeah.
Are there any other risk factors for osteoporosis or other diseases commonly associated with osteoporosis?
So first, family history, because that tells a little bit about your genetics for strong bones. So if you have family members that broke their hip, that had compression fractures, I would even start screening right at menopause, or, to have an idea how strong your bones are. So family history is a big one. Then there are many other risk factors like hyperparathyroidism, where your parathyroid is overactive. It takes calcium out of your bones, and that's one of the main reasons to treat hyperpara, is not to damage the bones. Steroid use, so patients on chronic prednisone because they have autoimmune diseases or they have some GI diseases that you need prednisone for a prolonged period of time, that damages the bones. Some anti-estrogen medication patients use for breast cancer treatment damages the bones. Medications that decrease testosterone in men because they have prostate cancer or something, that damages the bones. So a lot of medication can damage the bone. And then diseases like hyperpara. Smoking is related to decrease bone density, alcoholism, not have a good nutrition, low vitamin D, not as frequent in Florida, but you would be surprised how many patients have low vitamin D, because the only natural way to get vitamin D is the sun. So sometimes patients come with very low vitamin D, and without vitamin D, you don't absorb calcium from your diet. So vitamin D deficiency is a big risk factor there as well. And then malabsorption, patients that have GI issues, short gut, previous surgeries, or gastric bypass surgery, they just don't absorb calcium. And that can lead to poor bone strength.
Now, you mentioned a lot of medications, which can result in osteoporosis. That's not to say that they shouldn't take the medications to treat whatever disease they are being prescribed that medication
exactly.
for.
If they need the medication, they need the medication. Then we protect their bones. So sometimes they don't have indication for treatment based on their numbers, but if they're going to stay on high dose prednisone, even if they have just mild osteopenia, the same thing with those breast cancer medications, we already protect their bones so they don't decline quickly and they don't have a fracture.
What does screening look like for osteoporosis?
It's just, it's a bone density. So bone density is a low radiation test. So a lot of patients are afraid of too much exposure for radiation, and I tell them it's not high radiation. It's not like a CAT scan, and it's a simple test, takes maybe 15 minutes. They measure the density specifically of the hip area and the spine, because again, those are the two areas that we're more concerned about fractures. Sometimes they also measure the density of the radius of the forearm. And the reason for that test is the numbers are kind of related to your fracture risk. So many studies were done to guide us in terms of numbers, and so the correlation between how low they are and are you at fracture risk, is it worth giving medication or do you need medication? If you're not high fracture risk, you don't need medication to decrease your fracture risk. So a lot of times I look at the results, and you have to look at the age as well. So a 50-year-old patient with mild osteoporosis is still not high risk for a fracture. That same number, that same bone density result in an 80-year-old gives her 2-3 times that risk for a fracture. So you have to evaluate the patient as a whole in terms of like their bone density results, the age, the other risk factors, to decide, is the patient high risk or not? Should they be on medication to decrease their risk? So it's not a clear cut. You have to look at all those things to decide, do they need treatment or not.
And with the bone density scans, how often does someone need to be screened, and who needs to be screened?
So the screening guidelines are women above age 65. So I usually tell patients 5 to 10 years after menopause, or age 65, because sometimes we are missing some patients in their early 60s that already have osteoporosis. The official guidelines say 65. But then sooner if you have any risk factors, so family history, hyperparathyroidism, any fractures, you screen sooner. Or they had early menopause. So for example, some women have menopause in their 40s, so they should be screened in their 50s. And then if it's completely normal, you can repeat it in 5 years, because it takes many years for the bone density to decline significantly. So if your bone density is completely normal, you don't have to check it every 2 years. 5 years is enough. But if you have osteopenia, every 2 years, to see kind of the rate of decline, because most women will decline even doing all the right things that we're going to talk about: calcium, vitamin D, and exercise. A lot of patients get frustrated because their bone density continue to decline even though they have been doing great with non-medication that they can do. But that's the natural history of our bones. They continue to go, the strength continues to go down with age, even doing all the right things.
Now, you mentioned women with the guidelines, but you also said that men are not included necessarily. So which men should speak to their physician specifically about being screened?
So any men with risk factors. So if they had hyperpara, if they have family history, if they notice a decrease in height, that's a big warning for men and women. If they're shrinking more than 2 inches, they should get a bone density, because it could be already small compression fractures in their spine. Any fractures that shouldn't have happened, in terms of like they fell and they broke a femur or a hip, that means already they have osteoporosis. They should get their bone density done. If they go on prednisone, if they have any malabsorption, if they're on those testosterone blocking medications for prostate cancer, they should be screened for osteoporosis.
You mentioned a number of modifiable risk factors for osteoporosis. Of course, we recommend people quit smoking because for a number of health reasons, of course, but you said that also has an impact on bone density. But you also said something about diet. So what diet changes can be made to help prevent osteoporosis or treat osteoporosis if you're already there?
So a few things we can do to try to decrease the bone loss. It might still happen, but we make sure patients get enough calcium, vitamin D, and then weight-bearing exercise. Those are the things that can make a difference. There's a lot of theories out there that haven't proven, and that includes vitamin K and some other supplements that I tell my patients it's really not proven to make a difference, but it doesn't do you any harm if you want to take them. But what I do recommend to my patients is to have 1,200 milligrams of calcium, either in the diet or as a supplement. So I always ask them about diet, because if they have enough dairy, green vegetables, seafood that total more than 1,200, they don't need supplements for calcium. So overall, as a rule, a good serving of dairy products, so a cup of milk, a cup of yogurt, or a big piece of cheese has around 250 to 300 milligrams of calcium. So if your diet is rich in that, you already don't need to take calcium supplement. But almond milk is usually fortified with calcium. You can look at the label and see, usually it has around 300 milligrams of calcium. The same thing with oat milk. Then green vegetables have calcium, but it's not as much as dairy products. So kale, green beans, broccoli have about a third in terms of content of calcium compared to dairy. Seafood has some calcium, especially salmon. But again, it's not like people have salmon every day. So the big dietary content to decide if they need supplement is dairy. Like some patients have dairy a lot in their diet, they don't need supplements. Now, vitamin D, I always recommend, even if patients tell me they're out in the sun and doing yard work, because you just don't know if it's gonna be enough. You need strong sun. Again, in the winter, it's not as strong, so you really don't know if it's gonna be enough. So I usually recommend 2,000 of vitamin D a day. It's very safe. It's never going to be too much. So it's a good habit to just have vitamin D as a supplement. There is a good amount in some multivitamins. So if there is already more than 1,000 in your multivitamin, you might be okay with that. And you don't need to take extra vitamin D. But checking and making sure that it's enough, then you can just continue what you're doing with your multivitamin if that's the case.
Ideally, when would people start taking these supplements?
I would say sometimes I recommend even to my patients before menopause, because it's just healthy to have vitamin D so you can absorb the calcium that you're taking, right? We want to make sure your bones are strong even before you go into menopause. So also vitamin D is associated with overall health. Even very low vitamin D, you can have fatigue from that. So it's not a bad idea to always have a good amount of vitamin D. But especially for bone health, that's the main proven benefit of it. We usually recommend above 30. There are some theories that it decreases some incidence of other diseases, autoimmune diseases, and even cancer above 50, but that's, again, not really proven. For bone health, above 30 is enough.
You also mentioned activity level. So what exercises or stretches are most important in preventing or treating osteoporosis?
So weight bearing. And weight bearing can be even just fast-paced walking is weight bearing exercise. Weights, I recommend if the patients want to do something more than just walking, like stair is a great exercise, and squats, anything that actually goes against resistance is a great exercise. So I usually recommend, if they have the time, to do at least 30 minutes a day. If their exercise is more in the pool, I tell them, it's okay. Those are great exercises, but they are not weight bearing. So I try to tell them to do something at least after they come out of the pool, maybe do a little bit of weights, even if it's 10, 20 minutes, to get some weight bearing exercises there. But it's something important to say. I see a lot of patients that come saying, I want to try calcium, vitamin D, and exercise instead of medication. And one important thing to know is there is no evidence, there's no study that has shown that calcium, vitamin D, and exercise, even if you're great about doing all those things, that decrease your fracture risk. So ultimately, our goal is not to improve 0.1, 0.2 on a bone density scan, where the number has to mean something, has to come with a decrease in risk. So the reason we treat osteoporosis is not to improve a number, is to decrease the risk for fracture. That's our goal. So doing all the right things, if your number improved by 0.1, 0.2, doesn't mean your fracture risk is down. So those things are important part of the treatment. They're enough if you're in osteopenia and you're not high fracture risk. So we're trying to prevent it from going down to osteoporosis. But when you're in osteoporosis or when you're high fracture risk, calcium, vitamin D, and exercise are not enough. And that's when we talk about treatment, because we want to decrease fracture risk.
Is there a cure to osteoporosis?
We don't talk about cure because, your bone density, we can try to bring it to osteopenia into normal, but if we stop medication, it will go back down. So we try, instead of talking about cure, we talk about decreasing fracture risk.
So how do we decrease fracture risk? What does treatment look like?
So there's several medication approved for osteoporosis. And I see a lot of patients, they come to me because they have been declining treatment. There's a lot of bad press and misinformation out there. The old medication out in the market that a lot of patients know about is Fosamax, alendronate, and they really afraid of it. If it's from misinformation, sometimes from their dentist or from the internet. About 10 years ago, there was information coming out. Patients were they were on Fosamax and they stayed on it for many years. And about 10 years ago, they realized there is a side effect from the medication from prolonged use without giving patients break in between every few years. And that is called osteonecrosis of the jaw. It's a very rare side effect. Even with prolonged treatment, what we don't do anymore, they used to do back then when they found out those bad side effects. It's when you have, and then it usually comes with extraction or dental work that digs into the bone, and the bone doesn't heal well. So the bone dies, and that's what necrosis of the jawbone is. And it is associated with prolonged Fosamax or alendronate or those bisphosphonates. That's the generic class of those medications. But again, the way we do it now, since we know about this problem, is every 5 years, we do a drug holiday, we call. We do a 2-year break, let your bones recycle again before we restart it. Doing it correctly, the risk for necrosis of the jaw that was already very low is even rare. So we talk about now 1 in 10,000 to 100,000 patients. So what I try to explain is it's all risk and benefits, like everything we do in medicine and in life. So the risk for this rare side effect is so small, but if the benefits from the medication, if you really need the medication to decrease your fracture risk, the benefits can be huge. So we try to do it the safest way possible. If the patient has already a planned dental implant or extraction, we wait until they do it. If they're on medication and they need a big dental work, we ask them to stop for a few months, wait for it to heal before we restart. I'd say that way we keep patients safe and they still can have the benefits of the medication. So the medications associated with this rare but bad side effects are the bisphosphonates and Prolia. So we try to do the safest way we can, but I try to explain how rare the side effects are, how rare this is, and how much of a benefit they can have from medication. Some of those medications can decrease your fracture risk by 50 to 70%. So patients that have already a spine fracture, like they come to me already with 2 or 3 or more compression fractures in the back, we know that if we don't do anything, their risk for having another fracture is 50-50 in the next year. So really high risk for having more of those fractures. So we can decrease that risk by 50 to 70% with medication. So it's really worth it, that small risk for a side effect. And that's what I try to come across, and to explain.
Now, the treatments we've discussed today, even the bone density scan, all of this can be prescribed by a primary care physician. So who would come to see you, an endocrinologist?
I think patients that are having declines, even though they are on a good treatment, we don't usually see that, but it can happen. So they have maybe something else going on that needs to be ruled out. Why are they declining even though they are on treatment? Or if they fracture while on treatment. I mean, the medications don't decrease the fracture risk to 0. So it can happen that you'll have a fracture, especially if you have severe osteoporosis or if you have a bad fall, that you fracture on medication. But we want to make sure, again, that you don't need something stronger. There are stronger medications than those 2 we talked about just now. There are some bone building medications. So that would be the next step for patients with very severe osteoporosis, patients that already come with multiple fractures. We go a step further. We have injectables and newer medication called romosozumab that builds bone besides just stabilizing the bone. So those patients need to be seen, or the ones that come with very young with bad bones, to make sure, again, there is no reason for that low bone density. Patients that need the bone building one, I think they should see a specialist, because if the primary care is familiar how to prescribe those are daily injections. Like for Teo-Timlis, they're daily injection, and they would benefit of seeing an endocrinologist to also monitor them on those medications.
What does it mean to you as an endocrinologist? Or we've seen, as you discussed, these advancements in medications. There's more options now. Has that helped your patients? And do you think we'll continue to see these advancements in treatment for osteoporosis?
There's still, of course, studies being done all the time for new medications, because even in osteoporosis, we don't have a lot of options. We have, for bone building medication, we have the daily injections that have been out for about 10 years now, but we have romosozumab, that's a monthly injection that has been out for about 3-4 years now. So that's a newer medication, big benefit for patients that come with very low bone density or fracture. So we don't prescribe those medications in mild cases. It's kind of the next step. So we have a few options, and we have also milder options. So we have like raloxifene. It's a medication that looks like estrogen for the bones, so it's good for women that have very mild osteoporosis, mainly in the spine. It doesn't decrease fracture risk like the other medications, but it also doesn't come with the side effects that a lot of women are afraid of. So sometimes if they really don't want the other medications or they have some dental work planned and they really don't want to go on the medications that might increase their risk for those rare side effects, we have some options for that as well. So I think those patients that want more information, that they don't want to be on one or other medication, they would benefit of seeing an endocrinologist. The patients that need to have secondary causes ruled out, the patients that are definitely the ones that are severe with already multiple fractures, they benefit of seeing an endocrinologist.
If someone is listening to this podcast, watching this podcast, and thinks, I believe I have a risk factor, or I haven't had this conversation with my doctor yet and I'm within screening guidelines, how do you recommend they talk to who do they talk to? Do they go straight to an endocrinologist? Do they call their primary care?
I would say they call their primary care. They should get, if they have risk factors or if they're the age for screening, they should get a bone density and kind of assessing their baseline risk to see if they, even if it's just checking baseline blood work, and checking their vitamin D, make sure they're getting enough calcium, enough vitamin D. It makes them more aware that they need exercise and just trying to maintain their bone health. If they don't have osteoporosis yet, or they're not high risk for fractures, so at least they're aware of their bone health and they work on keeping it as much as they can.
Is there anything else you want patients to know? I know we've covered a lot today.
I would say just be careful with misinformation out there. Unfortunately, we hear this even from medical providers and from dentists, that they talk about the fear of those rare side effects, and patients get really afraid of going on medication. And sometimes they don't want treatment and they end up with multiple fractures because they have been afraid of those side effects. So overall, I tell my patients, go to good sources of information instead of just Googling osteoporosis and risk factors, because we know there's a lot of misinformation without any filter on the internet. And so, try to get from the National Osteoporosis Foundation has a good website. Some good medical institutions have websites with information on diseases. Those are good sources to read about osteoporosis and to have the real information on side effects, so you can make an informed decision, of a treatment that might really help you and might prevent a bad fracture that can change your life.
Do you think some people avoid even being screened because they don't want to know, because they're scared of this misinformation?
Unfortunately, we do see that. I have some patients that have severe osteoporosis and they say, I don't want another bone density because I won't treat it. And unfortunately, sometimes I see patients after they fall and they break their hip or their spine, they change their mind then. And that's what I try to avoid happening. And I try to explain to them. I said, with your very low bone density, you can have a fracture even without a fall, because that's another thing that I hear sometimes. Oh, I'm very careful and I don't fall. I'm very careful with falls, but some fragility fractures can happen even from just bending over and picking something up from the floor, or just turning, and and they can happen just spontaneously. We hear this unfortunately from spine fractures. They hear a pop, they turned, they can fracture a vertebra if their bone density is very low. So avoiding falls not a good way to prevent fractures. Unfortunately, when you go low enough, you can have even spontaneous fractures.
And the goal is that the treatment prevents these fractures.
Exactly, and that's what I explain to my patients. The reason for the medication is to decrease risk. And we have some great medications that decrease, like I said, even 50 to 70% the risk for fractures. And so like everything in life, risk and benefit. So I try to explain, if you're high risk enough, it's worth it, that small risk for a side effect. And we try to be as careful as we can, trying to postpone, like I said, after dental treatment, try to stop for dental treatment if we can. And one information that I want to actually use this channel to also tell patients about, that unfortunately some patients don't know about it and some providers don't know about it. There is a medication that's very commonly used called Prolia. That's every 6 months, is one of the best medications we have to prevent fractures. And a lot of misinformation about once you're on it, you can't stop, and that's not true. So you can't stop it cold turkey. It's a medication that if you want to stop, you have to change to a different medication for a year to kind of wean it off. Because if you stop it cold turkey, yes, you can have a quick decline in bone density and have a fracture. So it's another point that there's a lot of misinformation on the internet, and I try to explain to patients, no, once you're on it, we can take you off. We just have to do it in a certain way.
All right, Dr. Boldo, thank you so much for joining us today and answering all these questions. As always, we encourage everyone in the community to please visit smh.com to get the latest from Sarasota Memorial. Have a great day.